Just so you know, I'm Andrew Clark, and I direct the Institute for Municipal and Regional Policy, where we also help to convene the Connecticut Reentry Collaborative. And you can find more on the Reentry Collaborative, ctreentry.org. So the collaborative, as I imagine many of the attendees, had been planning to host events for Reentry Month, which just started April 1st. And we had our day set for the Capitol on April 15th. And as this pandemic hit, we became well aware, as did everybody else, that there was going to be a new normal. But we also felt the urgency to act and to do so in a way that honored Reentry Month and the issues that are very important to us. And so we quickly, through a series of meetings that we've been having virtually about 3 times a week, decided, let's do this virtually and let's have a series of 1 hour, 15-minute panels to bring light to issues, not just reentry related, but reentry in this pandemic. And we hope that they're informative, and we hope that you enjoy them and find value in them. And certainly if you have suggestions of other topics, we'd love to hear from you, but more on that later. First, what I'd like to do is kick it off. You should have with the invite a list of items for you to take a look at. One would be the agenda. And so you'll notice the first session, there were 2 agendas. One, we had lined up Mark Pelka, the current Undersecretary for Criminal Justice Policy and Planning, on the first panel. And unfortunately, Mark wasn't able to join us this morning, as we were also informed from DOC, Trina Section won't be able to join us as well. We're hoping to have them in future sessions. But we were very lucky and thankful that Mike Lawler, the former Undersecretary, was able to pinch hit for Mark. And obviously, an extremely informed former public official who has many insights and thoughts into this issue. So we're going to start off the first panel, and it's entitled Managing the Criminal Justice System in a Public Health Pandemic. I sent links to an op-ed that Mike wrote, and I believe, Mike, you've written a couple now. I sent the one from the Mirror where you indicated what Connecticut is currently doing, the state of its incarcerated population, numbers in decline, but also what could be done. And I was thinking it might be good for you to kind of summarize that and give your thoughts. Where are we? There was a New York Times article just today in the front page on Rikers Island. I know there are a number of people that are concerned about loved ones inside and what the system is doing to respond, and would love to hear your thoughts on that from your perspective, knowing the system, not just from the former Judiciary Chair for a number of years, but also for our Undersecretary for 8 years under the Malloy administration, which wasn't that long ago.
Seemed like a lifetime ago. Can you hear me okay?
Yes.
Awesome. Well, good morning, everybody. As Andrew just said, I'm kind of pinch hitting for Mark, but I always want to be clear up front. I'm absolutely not speaking for Mark or for the administration or for anybody except for myself. And so I can't answer questions about policy decisions being made at the moment, but like many of you, I'm an obsessive observer of all of the trends and the data that we've been seeing, especially over the last month and a half as the COVID-19 crisis sort of washed the shore here in Connecticut as well. So a couple of things, and I feel the only useful role I've been playing recently is to try and help people understand the complexity of Connecticut's criminal justice system, whether we're talking about journalists or legislators or just regular people. What are we to understand from these numbers that we see kicking around? And I know many of the people on the broadcast today are themselves experts on most of the stuff I'm going to say, but I just want to point out the actual numbers, because when you think about reentry, when you think about people leaving correctional facilities and reentering the community, it's important to understand how many different categories these people tend to fall in, and what kind of mechanisms are being used to have them leave the facility. So a couple of things. First of all, I think as most of you know, over the last 6 weeks, we've had a dramatic, really unprecedented reduction in the number of people incarcerated in our state's prisons and jails, right? Since March 1st, the total incarcerated population has dropped by 790. That's a huge drop over just the space of about 6 weeks. Each day, that overall population is dropping by somewhere between 40 and 50. That's not the case on weekends, because I think it's the case that the DOC personnel who are involved in these release decisions don't actually work on Saturdays or Sundays. But every other day of the week, the reduction in recent days has been somewhere between 40 and 50. Last night, the total inmate population dropped by 42, right? And I have every expectation that will happen tomorrow and Thursday, and Friday and Saturday, because Saturday you get the numbers based on what took place on Friday. So my guess is over the course of the next month or so, it's not at all unlikely that the total incarcerated population will drop by probably another 1,000 or so, I'm guessing. And I'm sure as many of you are aware, right now our total incarcerated population is back where it was in 1992. So we're at a 28-year low, dropping rapidly. We're down about 40% from the all-time high, which happened in February of 2008 in the aftermath of the Cheshire murders. And so we've had a very steady decline for 12 years now, but what's happened in the last 6 months, it's just sort of dropped off a cliff. And if you look at the graphs that chart the total incarcerated population over time, you see this cliff starting on March 1st. So it's really extraordinary. It's happening in a lot of states. But I think this is an opportunity for everybody who cares about successful reentry, right? On the one hand, you're getting a lot of people coming back. On the other hand, we have a well-known shortage of resources to help match up these individuals with the support, the programs, the housing, the health care that they need as they're coming out of correctional facilities. So with that in mind, let's talk a little bit more about this 790 drop in the total population. One mistake that many people seem to be making, especially journalists, I know this is not the case for most people on the call here today, but they assume that means 790 people were released. That's not what that means. What that means is the net change in population was minus 790 over the last 6 weeks. But in a normal month, even before COVID, if you just look back in February of this year, about 1,700 people were released from the Department of Correction in a normal month. So what's happening now is that normal outflow has increased. And on top of that, although we don't have the hard data for this yet, the inflow, the people being admitted to prisons and jails, seems to be down dramatically. So what you're seeing is the normal outflow has been increased by a fair amount, and the inflow has dropped by a lot. And so it is not the case that there's been an across-the-board decision just to release 800 people just to get prison, to a more manageable population in light of this contagion that is spreading in some facilities but not yet in others. It is a gradual change that's happening day by day by day by day, right? As I think most people on this also know, that the status in which people are being released from prison, it can be very different. So let's just take the pretrial population. Here's what we know. If you get arrested and you go to court and a bail is set and you can't post that bail, you end up sitting in the Department of Correction. In a typical month, the people in that category, which are usually somewhere around 800-900, sometimes higher, end up getting released in different ways. So there are some people who are locked up pre-trial and can't post bail, who actually post bail and are released. That's a type of release that's happening all the time, always has. The other type is people who can't post bail and they're sitting in jail pre-trial, go to court, and then don't return. In other words, they went to court and something happened in court which no longer required them to be incarcerated. Perhaps the charges were dropped, or perhaps they pleaded guilty and got probation, or perhaps they pleaded guilty and got some type of time served sentence, or perhaps they got some sort of diversionary program. But we know every month, even before COVID, about 600 people would go to court from jail and not come back. And that's a category of reentry that we need to be aware of. People are being released from courts, not from jails or prisons. And how to capture that is complicated. As I said, many of these people are going on to probation. And so that shifts over to CSSD to manage that category of reentry. Now, anecdotally, we don't have the hard data on this yet, but it sounds like that category has actually shrunken because, as I think we all know, a number of courthouses are closed altogether. The ones that remain open for criminal cases, they're focused mainly just on arraignments. So the normal pace of people coming back to court and resolving their cases seems to slow down a lot. A lot of prosecutors, a lot of judges are not going to work every day. And that does affect, and public defenders, I'm sure as well, it does affect the ability for people who have been locked up pretrial to get their case resolved and be released. Normally, that would be a pretty big number. As I said, 600 or so every month. We don't know how many it is in the last month, but my guess is it's down quite a bit. Right? So that's one category. The Department of Correction has a lot of authority over many of the categories of releases. And in many of these cases, judges don't have a say, the parole board doesn't have a say. And I think people watching this understand this, that the big category here, which has always been the largest category for early releases from prison, so to speak, is transitional supervision. It's the sentenced offenders who are serving a sentence of less than 2 years. They're not eligible for parole. Whether or not they get released and when is a decision made solely by the Department of Correction. And DOC has a team that was set up 6 or 7 years ago that manages all of these release decisions. It's called the Community Reentry Unit. It's a small group of highly trained professionals with a lot of experience in risk and needs assessment who are working out of a small house up in Summers, what used to be like a warden's house up there. And every day they make these decisions, but it's clear that the single biggest increase in release has been in this category, the people serving less than 2 years as a sentenced prisoner. The number of releases in this category is quite high based on all the data we've got so far. I think we'll get more when OPM releases their monthly indicators report in a few weeks. That will cover the month of March. But if you look at the day-by-day data in terms of number of people incarcerated serving a sentence of less than 1 year, which is something you can track every day, see a big reduction in that category. So presumably that means that most of the focus on sort of expediting releases has been on these relatively less serious offenders, and you can tell they're relatively less serious because they got a relatively short period of incarceration as a sentence. That doesn't mean they're all safe or don't pose a danger to the community, but it means that's a good indicator to start with, and it's clear to me at least that's what the Department of Correction is focusing on. At the very back end, you've got some parole decisions which are very discretionary that require deliberation by the Board of Parole in terms of like release of long-term inmates who are medically compromised, have been incarcerated for a long time, are elderly, at very high risk of not just becoming infected with COVID-19, but also having a really bad healthcare outcome. So it doesn't sound like that is being utilized to the full extent, but I think it's worth keeping in mind that many of the people we're talking about are serving lengthy sentences for serious crimes where there's victim involvement, et cetera, and there has to be some sort of due process proceeding to figure that out, right? There are some other options available to the commissioner, for example, the nursing home release for people who are severely medically compromised and are appropriate for a nursing home. I don't know how many available beds there are at the one facility for this in Rocky Hill. Typically, there was about 30 or so empty beds there. So that's another option. But that's not really a reentry issue because to the extent that's going to happen, it's going to be totally managed by the by the healthcare professionals at this nursing home, which is a private nursing home. A couple other smaller categories. There's the DWI house arrest mechanism, which has been extremely successful over the years in reducing recidivism by repeat drunk drivers. Obviously, if you were trying to identify people who don't pose a direct risk to the community if they were to be released, a lot of the DWI offenders are serving mandatory sentences for repeat convictions. Now, it's not to say that drunk driving isn't a serious public safety issue, but it can be managed using technology, the ignition interlock device, et cetera. But it does require some intensive effort by parole officers to supervise this crew, which brings me to the final topic, which is the category of incarcerated people that technically are classified as unsentenced by DOC data, who are actually parole violators. And there would typically be 200 or 300 or 400 people who are incarcerated on any given day. And the reason for their incarceration is a violation of parole. Probably, I'm guessing the lion's share of this group are special parole violators. And a fair number of these violations are technical in nature, right? And in other words, don't result from a new arrest. And even the ones that do result from a new arrest, a lot of times it's a relatively minor arrest that's been already adjudicated in the court where there was no additional prison sentence imposed, but they are awaiting a parole board hearing on whether or not the length of their incarceration as a penalty for that violation. And this is something that is completely under the control of the parole board, not the DOC. In other words, whether or not to impose additional period of incarceration or to expedite the hearing to determine whether or not they need to be locked up for additional time as a result of their special parole violation or regular parole violation. And I think this is a high needs group because they obviously were released and they're not being successful upon their reentry and are being brought back. A lot of times the sentence imposed then is more or less arbitrary, like a year or 6 months. There doesn't really seem to be a lot of science behind the length of incarceration. But I'm saying this is a group that's ripe for special focus by the reentry community because these typically are relatively high risk plus relatively high needs individuals who, with the right kind of support would probably be successful upon their release. So that's like the big picture, what's going on now. The bottom line, it is very dramatic. This is completely unprecedented that the total population would drop 40, 50, 60, 70 each day. And as I said earlier, this is likely to continue for as long as we have this social distancing like lockdown thing. For those of you who are advocates, let me just give you a talking point that I think is very important to stress, and that is we're not just simply talking about the well-being of individuals who are incarcerated or who are reentering. We are also talking about the well-being of the professionals that work in the correctional facilities and their families. And we are also talking about the well-being of everybody in the community, because if in a typical month you have 17, 18, and maybe at this point 21, 2,200 people leaving a correctional facility, all of those individuals are going back into the community in some fashion. And if they are bringing with them contagion that they have contracted while incarcerated, they're exposing all of the rest of us to danger. I mean, imagine if there was a cruise ship anchored in New Haven Harbor where we knew that there was a fair number of people on board that cruise ship who were testing positive or suffering the symptoms of COVID-19. And every day, 50 people were going on the ship, and every day a different 50 were coming off the ship. I think people would shut that down immediately. They would not put any more people on it, and they would carefully deal with the people coming off it. And I think that's how it's important to think about correctional facilities. For those of you paying attention to the news, you're aware that around the country, in jurisdictions, that there are significant release initiatives going on in county jails being undertaken by elected county sheriffs. So politicians are making these decisions elsewhere in the country. Many of these people are very conservative, very Republican. Not that there's anything wrong with that, but I mean, these are not do-gooder liberals for the most part making these decisions. These are people who are very focused on containing this contagion. Same thing in states. We saw Governor DeWine in Ohio, a very conservative governor who has been very emphatic about the importance of reducing the prison population there. And you saw the governor of Kentucky and other governors doing this kind of thing. You've even seen Bill Barr, the Attorney General of the United States, who is not anybody's poster child for criminal justice reform, saying that they are making a very dramatic and focused effort to reduce the number of federal inmates who are at high risk for this virus. So this is something that is happening not just in Connecticut, but around the country. It's a very good sign. And I'll leave you with this. This is how I've tried to articulate this. We know that immediately when the contagion became clear, right, when it was clearly going to be a major problem for the country, the first thing that hospitals did was cancel elective surgeries. And they said we need to focus all on what we're about to receive, which are intensive care patients who are going to be coming in the front door because of COVID-19. I think the way to look at our correctional population right now is we need to cancel or postpone elective incarcerations, right? People who are actually literally dangerous to the community are appropriately incarcerated and incapacitated. But that is definitely not the majority of the people currently incarcerated in our state. And I think the focus should be on identifying who needs to be incarcerated, not to focus on who deserves to be incarcerated, because later on we can always deal with the failure to appear crowd and the violation of probation crowd who don't pose an immediate public safety danger and be held accountable later. For now, we need to get our prison population as low as possible for all of our safety. So with that, Andrew, I'll shut up and happy to answer any questions.
Oh yeah, and Mike, as always, that was tremendous and a great overview, as well as some ideas for people to have in asks that you can make of the system of our elected leaders. I had one question, and then I want to go to Lisa, and that's did you mention the technical violations from probation population?
Yeah, so I'm sure there's some CSSD people on here as well, and they could provide more insight into this. But I mean, the good news is over the last 10 years or so, CSSD has adopted a system of properly managing violations of probation. I think, as most people probably know, the number one category for which people are incarcerated in Connecticut today is violation of probation, more than for murder or robbery or drug dealing, anything. And starting about 10 years ago, the system by which these decisions to violate someone's probation is managed, or for technical violation, has been subjected to a number of layers of oversight. So in other words, a line probation officer is no longer able to simply violate somebody because she or he decided they wanted to do it. They have to go through a chain of command. So I think the number of those is lower than it used to be for sure, but there still are quite a few who are in there for technical violations. And don't forget, in addition to that, people who are on probation who get arrested for a new offense are typically charged not so much by the probation officer, but once they get to court, prosecutors will routinely add the charge of violation of probation based on the new arrest. And that gives a fair amount of leverage in plea negotiations because, a violation of probation, you can easily be sentenced to whatever the suspended sentence was without you don't even get a jury trial. I mean, it's just a hearing where hearsay is acceptable, et cetera, et cetera. So those aren't, strictly speaking, technical violations, but the new arrest could be anything, right? And if somebody is on probation for something relatively serious, but gets arrested for, let's say, possession of marijuana or drugs or whatever, I mean, it's not an indication of dangerousness, even though it's not technically a technical violation. So it's a long way of saying, if you're looking for the low-hanging fruit of people that don't need to be incarcerated, you would definitely start with the pretrial violation of probation population, because almost all of them have some sort of bail set. And then you could look at the sentence, the violation of probation population. For each of these offenders, CSSD has a wealth of background information, risk and needs assessments. And so, I mean, this is a time-consuming process, but I think if people put their heads together, a team of experts from DOC, parole board, probation, prosecutors, some experienced criminal judges could probably go through a list of 1,000 candidates and easily identify 500 or 600 people that don't need to be incarcerated today. Again, it's a question of not who deserves to be incarcerated. It's a question of who needs to be incarcerated at this moment. So the technical violations of probation and parole are I would start there for sure.
Thank you, Mike. And, you know, what you said at the end with the cruise ship and also who needs to be in there, I think is a perfect segue to Lisa and the medical community, because essentially, you know, this was also in the New York Times article, the lens by which this pandemic is being looked at in many areas is the public health lens, not necessarily the criminal justice lens solely. So I'd love to bring in Lisa for her thoughts. I mean, Lisa, I think it'd be good to give a little background about the work of the Transitions Clinic, because those people that Mike talked about who have medical conditions that come out into the community are folks that you deal with every day. And then this pandemic has only exacerbated that. And I know you wrote an op-ed as well with some of your colleagues and myself, and I shared that with folks too. So I'd love to hear your thoughts from a public health perspective of who needs to be in and what has to happen, and what is important for the community in order to get ready for people coming back.
Thank you so much, Andrew. I appreciate the opportunity to be here. And for people who on the line who don't know me, I am a primary care doctor and internist at Yale, and I direct our clinic, which is called Transitions Clinic, which focuses squarely on the health needs of people who are leaving correctional systems. So that is what I dedicate my clinical work to. And we also do research on the intersection of health and incarceration with our health justice lab at Yale. So from that vantage point, I can say a couple things. You know, I'm sorry, I'll add in one other thing, which is that we're part of a national network. So Transitions Clinic Network has now close to 50 different clinics across the country. These are all programs within already existing community health centers. And so what we benefit from is a more national vantage point. So we're able to speak to what's going on between health and incarceration in a number of different states as well. And I would say a couple things. I agree with what Mike Lawler said, you know, about the cruise ship analogy. I think it's a good one. I think the most important point is that this isn't a unique correctional crisis. That it is, but what it is at its very core is a public health crisis. Like, no one on this call, no one in this generation has ever lived through a crisis of infectious pandemic to this extent. So it's unprecedented. And so the things that we'll need to do to meet the challenge are going to be unprecedented. So that we're releasing more people than we've ever released in a month is phenomenal and necessary. I think it's not uniquely special that we're doing it. It's what the time and the crisis calls for, right? So I'm glad that we're able to do that, but we're going to need to continue to do more. And I would also say, like, from the vantage point of a medical professional and, you know, on the emails at Yale of, you know, all the guidelines that are coming out daily, like, from the health standpoint, we are working on it around the clock. It literally never stops. The ways that we've had to organize and reorganize how we deliver health over the past 3 months has been entirely unprecedented, right? We're shifting people out of hospitals. We're turning gyms into, you know, makeshift hospitals. It's totally unprecedented. And people are putting their lives on the line all the time. Like, we're asking health professionals to do things they're maybe not comfortable doing, and they're kind of rising to the challenge and just getting it done. And I think that has to trickle over into other agencies and other workforce members in our state to meet the needs. And so when we speak about correctional health, and what I can't speak to is who should be incarcerated. That's just not in my wheelhouse. That's not my expertise. But what I can speak to is who shouldn't probably be incarcerated. We know that people in our correctional systems have higher rates of chronic illness than anyone in the community. And therefore, projections as to how infection spreads and affects people in the community are just inadequate when it comes to projecting in correctional systems. This has been shown in other infectious diseases over time and is going to be particularly true now. This is a nasty illness. It lasts a very long time. It makes people, even who have more mild cases, we call them mild, but they feel incredibly ill. And it's unpredictable. The flu, you get it. If you've had the flu, you kind of more or less know what to expect. This isn't like that. You'll be doing okay, and then suddenly on day 10, you turn a corner and need to be intubated. And so it's unlike other illnesses that we've seen in the past. And it's very likely, we already know it affects people who are older, people with chronic health conditions, and increasingly that's the population of people who we incarcerate, people who have a lot of medical illnesses, and the age of the people inside is increasing quite a bit. And so we'll need to do really unprecedented things, and the community will need to rise to the challenge of helping people once they get out. What do I mean by that? I think that we need to ask a lot of the DOC and our leaders, our governor, in terms of really getting people out as much as possible. And we have to be prepared in the community to meet their needs, because you can't just get people out and then desert them. I don't know that we've accomplished much if that's what we're doing. And, working with all the time with people who have been incarcerated and listening to them, and we do a lot of participatory research. So people who have been incarcerated in the past are, center and core to the work that we do. It's, squarely framed around their inputs and priorities are saying to us on a daily basis, like, this is scary. You get out and there's, a lot of uncertainty, and now there's agencies that are closed, health centers that are, not taking walk-ins, and it's really hard to figure out sometimes how to center yourself and protect yourself and stay alive and care for your needs. So I think it's important as community reentry partners that we too, everybody, no matter what angle you come to it from, whether it's housing, whether it's food, whether it's jobs, whether you have connections to cell phones, which everybody's going to need, because the analogy I use is like we're asking healthcare professionals to put themselves in uncomfortable positions and rise to the challenge. And we all need to do that too. So it can't really be just business as usual. I'm thinking right now of a person who I've been working closely with the DOC and trying to help arrange a safe discharge for him. He's a very medically complex individual. And, just saying, oh, here's, a phone number, call the community health center and try to talk to them over the phone. This is just not going to work, right? This is probably somebody who just really needs to be seen in person. We can't assume this person's going to have a cell phone. Can't assume if someone's been in for a while that they're going to know how to really access care and utilize it. And so whereas we may say, okay, well, it's not safe for us to be open right now and we've got orders not to do that, like there are going to be some situations around which we have to get much more creative in order to really meet people's needs. A few last points, I would say that to echo what Mike Lawler said, and to put it even a little further, like correctional health is community health. The two are intimately intertwined and cannot be disassociated from one another. So large correctional outbreaks, which we are still very much at risk for in this state. I've been plotting the daily number of infected cases over time, and it's, you know, increasing. The doubling time is quite short in our Department of Corrections. And I'll say that the risk as well, in addition to people's lives who are incarcerated, who are the most important, is also that it's community, right? So a lot of these facilities are up north in our state. Where are they all going to go? Lawrence and Memorial Hospital, probably, right? So when you get a lot of people sick all at once, the infectivity of the coronavirus is in correctional systems is not entirely known yet, but it's likely much higher than infectivity in the community, and infectivity in the community is already 3 times as high as for like influenza. So what I mean to say by that is what we're seeing in other correctional systems is, you know, based on that, and it almost acts more like on a cruise ship where you're in just such tight quarters. It's not that one case is easily managed. These cases multiply, these infections multiply very quickly and have the real possibility of inundating as well the community health system. I say that to just really drive home the point that it is, like, what's happening in there is relevant to everybody, whether they think it is or not. It is entirely relevant to the community as a whole. And because of that, I think we all need to be asking for transparency. You know, I am sensitive to the fact that the word mass release seems very political and probably garners a lot of reactions. I think, you know, I can squarely say, and like not being naive, this is just not a political issue. It's about trying to stay alive and keep as many people in the community alive as possible, period. End of story. And so, you know, I just think that we have to really frame it like that. And whether you want to call it mass release or not, and I'm glad to see that we are releasing a lot of people, and I've seen that firsthand running the hotline that's helping release all medically complicated people. I'm getting a lot of calls, and that makes me happy to see. But I do think we just have to keep in mind that there's still a real risk of cases exploding in the DOC and then inundating the community system as well. And so, you know, I think it's, to summarize, it's all hands on deck. That means all community hands on deck in helping to get people out safely from our correctional systems. And we need a really clear plan from the DOC. We deserve that because what happens in there affects everybody in the community. And public health should be at the center of it, as this is a public health crisis.
Thank you so much, Lisa. I really appreciate those comments. And one thing I'd like to mention is Transitions has set up a hotline for, you know, halfway houses and correctional parole officers and other professionals who are dealing with folks being released to provide some medical assistance. Would you mind just mentioning that real briefly?
I should be more clear. So, you know, in order to do our part and not just ask the DOC to release people to like a community health system that's largely closed, we created a hotline that anyone in DOC can use. All the reentry roundtables can use. They've been, you know, handing it out to people as they walk out the door to say, like, we will figure it out. So if there's a complicated discharge medically, or somebody gets released and doesn't know how to fill medicines, or has a new problem and doesn't know how to reach a physician, and we're telling everybody not to go into the emergency room, this is a number where we will answer it and we will help people just figure it out. We're kind of like, to some extent, making it up as we go, in the sense that we don't know what all the needs will be, but we are figuring it out on a day-to-day basis and having a lot of success with it. We're calling on our community partners and like calling on favors and saying, like, you know, this person's leaving right now and needs methadone tomorrow morning. Your office is closed. Like, how can you help me set it up so that they don't go without a vital and necessary medication. And so that is the part that Transitions Clinic has done to really try to own leading the health challenges and figuring them out to make it that the complicated medical person, the complexity of their ailments does not bar them from being released.
Thank you so much. And at this point, I'd like to go to a few question and answer segments. If I want to also acknowledge that we have who joined this call is Senator Gary Winfield, the Judiciary Committee Chair, who I know has expressed some concerns and has some questions. And certainly, Senator Winfield, if you had any. You know, what I'd like to also do is acknowledge that the Transitions Clinic has been tremendous to the work of the Reentry Collaborative as we think about what we can do. And we've been working hand in glove, in particular with the end of sentence population, who we were already working with, and figuring out what needs are there and how do we meet them. And that's going to be part of the next panel discussion. I do want to, again, plug our website, ctreentry.org. We have a COVID page, which has, Lisa mentioned, a list of the resources, and what's available is changing rapidly. So we try to have those updated as much as possible from each roundtable catchment area. And there are 10 of them, the major cities, and also Wyndham, Danbury, Torrington, New Britain, and the like. So, so also on there is a hotline that we created, thanks to Brittany, our host today. It's a Google line that we've been getting a number of calls from concerned loved ones about what are the you know, just wanting to know what's happening with their loved one inside. Is there a possibility they get released? And we take those calls and we send them right to DOC to hopefully resolve them. We've had a number of them resolved very quickly. They've been very responsive. And if they have any concerns about, you know, once someone being released, what can they do? You know, they might have alcohol issues or public health issues or the like, and we send those concerns to the respective roundtable folks to be able to address them. There was one gentleman who was released from a prison in Massachusetts who had 7 days left of blood pressure medication, and he had been cutting them in half to try to deal with that, and he didn't know how to get more, and he was at a loss, and we sent them through the hotline to Transitions, Lisa, and I know you guys set them up with, I think, 30 or more days of that. So just an example of everybody all hands on deck approach that you mentioned. So I am looking if there's chat. So Gary doesn't have any questions at the moment. And so at this point, what I'd like to do is just turn it then to the next panel. And if there are questions at the very end, we can go to that too, because, you know, I also want to be mindful of time. But I really want to thank Dr. Puglisi from Transitions and Mike for your participation here. A tremendous amount of information and stuff for us to chew on, and things that we can do and calls to action, as well as just an overall understanding of the system and where we're at right now. So thank you so much. And now I'd like to start the second session, which will bring on Daryl McGraw, Sue Gunderman, and Beth Hines. Brittany, hopefully we can turn on their, and each of those individuals can turn on their cameras. And so what I'd like to talk about is, you know, as I mentioned, the Reentry Collaborative was working with Trina Sexton and has been working with Trina Sexton she's the new director of Reentry and DOC, a position that was created by Commissioner Cook, and she's only been on the job for about 9 months, and has been tremendous to work with as a real concern for the population. And their unit with the reentry counselors has been focusing on the end of sentence population. This is a population that gets out regardless of discretion or the like. They're just essentially let go. And as we've been finding out, and a number of them have been released previously to homelessness and situations which are untenable on a regular basis, but in the midst of a crisis certainly are not anything that we want to have happen. So we've been working them, and I know Sue and Beth, through the Hartford Reentry Center, you already had an MOU with DOC for the end of sentence population, which traditionally is a population. I know there probably are concerns from folks, and rightfully so, about why is DOC releasing folks to homelessness. And I think DOC acknowledges that, especially through this pandemic, that that's not okay. But it's also communities and places where people are coming to that hadn't taken ownership of that either. My experience in living in Hartford for 30 years now is mayors were not running on people being reentered successfully. They were running on people feeling safe due to arrest and the like. And so this switch to being concerned about the reentry population really has been in the last 5 to 10 years at the most. And so what that means is building the systems and the capacity for communities to be able to effectively handle people has been relatively slow going, but it's been persistent. And I think what this pandemic has done is given an opportunity to put that stuff into high gear. So I'd like to bring on Beth and Sue to talk about, you've been handling some of the end of sentence folks being released and into the Hartford Reentry Center. Tell us a little bit about the Reentry Center. You were operating before the pandemic. Hours have changed. Things have changed. What are the types of things that you're seeing, and what are also the things that the community could do to assist you as you attempt to assist people being released?
Beth, you want to give an overview, and then I can chime in on what we've been working with Trina and stuff like that?
Sure. So good morning, everybody. I'm Beth Hines. I'm the Executive Director for Community Partners in Action. And along with our partners, we operate the Hartford Reentry Welcome Center in City Hall. And so when COVID, hit, we realized rather quickly that there was no way we could shut our doors. People were going to be released, and we needed to be there to help them. So for the participants that we work with that have already been released and are in the community, we've been working remotely with them, keeping in touch with them, making sure that that their basic needs are met, any support services that they need, we're able to connect them with, as long as they have phones and are able to maintain contact with us. The biggest initiative that we have going on right now is working closely with Trina Sexton and the Department of Correction to determine exactly when people are being released end of sentence to Hartford, and coordinating that release with a warm handoff to the Hartford Reentry Welcome Center. And then we ensure staff are protected and the participants coming in are protected with PPE. And we're really well prepared for that release based on the information from the department. So we're going to know if they're going to need housing. We'll know that ahead of time. And if that's the case, we're coordinating with the Connecticut Coalition to End Homelessness, and able to obtain funding to place people into hotels. We've also been able to help out the participants with what we call reentry backpacks that are filled with items that they're going to need, such as hygiene items, gift cards for food, clothing vouchers, and the all-important cell phone, and at least 1 month of service. And that's so critical right now because they need to be able to maintain remote contact with us, and then any services that we're connecting them to remotely, they're going to need that smartphone to do that. In terms of the way people in the community could be helpful, are donating any of these items to the Reentry Welcome Center. You can reach out to me or Sue or Deborah Gala to coordinate any such donations, but certainly hygiene items, bus passes, gift cards for food and clothing would be very much appreciated. You can also make a monetary donation to the center through the Community Partners in Action webpage. There's a way to donate there, and you can specify exactly what you want your donation to go to.
Hey, Beth, let me just put a pin in that real quick because, you know, we found out through the CCSU Foundation that one of the things that, you know, drove down donations, direct cash donations, was the change in the deductible amounts. And so people were less incentivized to donate, and not to say that people shouldn't just donate out of the goodness of their heart, but one of the impacts of the stimulus bill and what was changed is people now can take the standard deduction, but up to $300 you can give in cash, and that's above and beyond the standard deduction. So that's changed. So hopefully that will be a motivating factor for folks as well.
And you know, we've been so blessed that people have been incredibly generous, and especially lately. You know, we can only buy 2 cell phones at a time. There's a regulation, and so our staff are going to Walmart every day, getting the 2 phones to make sure that we have enough phones for people coming home. But even, you know, just listening to Dr. Puglisi, we've been working really closely with Dr. Puglisi, especially on people coming out who have significant medical complications. There's actually a release next week that we've been working very closely on. So it's been a challenge, but I've got to give a huge shout out to Sue Gunderman, also to the city for allowing us to stay open when we need to be open on the days people are being released, to the department for coordinating these efforts with us, and to my staff who are there on the front line waiting for people to come home.
Thank you so much, Beth. And actually, Sue, before we go to you, what I'd love to do is, I see Daryl's now on, is, you know, we've talked about impacts of people and people being released, and I know Daryl, through his work with us, you know, has a unique perspective of being inside during 9/11 and a few other situations where there's lockdowns and real concern, and then how that impacts people being released. So, Daryl, I'd love to bring you into the conversation. You know, Mike was talking about on a good month, roughly 1,700 people leaving prisons. You know, from your perspective, you know, what do you think is needed, and what should the public know and elected officials know about that?
Thanks, Andrew. Hi, good morning, Sue and Beth and everybody that's on the call. I appreciate everybody. I want to just, you know, listening to this call, I kind of woke up a little depressed this morning thinking about how this, you know, having every day I'm worried about those individuals that are incarcerated and how they're faring well behind, you know, having to go through COVID. We got enough for those of us that are here. I hear people down and they really don't understand what real lockdown is like. You know, having, and you know, there's a lot of reports about limited soap. Always limited soap. So I can't even imagine, you know, the things that brothers and sisters are going through. I would like to take a quick second and shout out those advocates and people that are in the streets advocating on all different kinds of ways, from the ACLU to the Cattell Foundation, as well as Stop Solitary Connecticut and those other, because there's so much advocacy that needs to be done. So those organizations are organizing and keeping the conversation up front, and I really appreciate that. While we at the IMRP are on the phone calls, having those direct conversations with the roundtables and being part of the Reentry Collaborative and working with DOC and other organizations like the Coalition to End Homelessness. So we're at all fronts. We're trying to attack this as Dr. Puglisi said, this unprecedented event. What makes me sad, though, and you know, I know this wasn't, I don't know, I might be going off script a little bit, but you know, when the election time came, when there was elections and everybody was running for quote unquote governor, you know, they were in they called the people in the recovery community, they called the people in the reentry community to support them, and they told them and how they were going to help this population. Now, here, you know, you see people around election time, but you don't see these individuals in the times of need. Now, I did see something recently where we could call a governor, and but we didn't have to call a governor when I was at the NAACP event. We didn't have to call him. He was right there with his running mate, and they were talking about how they were going to support second chances and individuals, formerly incarcerated individuals, how they were going to support those people. And now we have to like basically go to his house and bang on the door to get support for those individuals that are locked up. I really appreciate the information that Dr. Puglisi and Mike Lawler presented with. That was helpful to give us some insight. But you know, having been in a cell during like 9/11, or when there was an outbreak of when we had a stomach virus that locked the whole jail down, it's automatically reactive, you know, and individuals can't use a phone. So you don't know what it's like on the other side. You know, I shout out to Commissioner Cook and his team and Trina Smith because we have open dialogue with them now. So I really respect that we can talk to them, but a lot more needs to be done. Mike himself just pointed out several areas that we could already touch and started to release some of those individuals, those technical violation individuals and so on and so forth. One of the people that, you know, being on that 1-800 call, you know, and answering those calls that we have set up that hotline, you know, we get calls from family members who said people are in prison for child support, you know, and this individual, one individual in particular, he's in prison for child support, where if he was released, he could potentially be working and home and not, like his family said, at risk of catching COVID while inside for a financial issue. So there's many different scenarios, and we want to, you know, continue. I'm going to stop there because I could talk the whole call about what we could be doing, but I really want us to, as a community, to continue to come together and address these issues. And I'm looking forward to hearing what Sue and Beth has to say. And by the way, work with the reentry centers, in roundtables. If you don't know about them, you need to find out because there are 10 roundtables in our state that we do this work every day, pre-COVID, during the COVID, you know, so we're on the ground doing this reentry work, and I think that we need to more. I see there's 154 people on the call. We need to stay connected and start moving the needle. And last thing that I will say is that, you know, those advocates that are advocating, we can't let it stop here. You know, we think we learn either a whole complete organization handling community reentry, or someone really somebody listening at the top. There's some leadership issues that don't really understand what really needs to be done from the reentry standpoint. I'll stop there.
All right, thanks, Daryl. I just want to make sure, Brittany, if you can mute all the attendees. I don't know.
Yes, that is the speakers that I need to mute themselves.
Oh, okay. All right. So speakers as well. If you have outside calls coming in, we can hear it. But thank you so much, Daryl. You know, I've heard there's also some questions and answers that we won't be able to get to on this call, but you know, we will make sure to send a follow-up. We're taking them all down. There's questions, you know, about can used cell phones be donated? What about personal protective equipment? You know, the PPE. I know there was an issue with that, Beth, within halfway houses and the like. and I know through Dr. Puglisi and transitions, the value of not just a burner phone, but of a smartphone to be connected with the new telehealth system, so that people, as they're sheltering in place, are able to get prescriptions filled and the like, and communicate with their doctors is really important. So, Sue, why don't we bring you on? Tell us a little bit about the Reentry Center. I know in the communications we've had in the past, week or two, you've had a number of folks that, how does it work? People are dropped off, and then you're trying to figure out what's happening and what you can do so that people are at least in a place where they're not in immediate crisis.
Right. Thank you, Andrew. Thank you, everybody, for being here. And I'm just excited to be part of this conversation. I'm the interim director for Reentry Services for the City of Hartford, and I'm also one of the co-chairs of the Greater Hartford Reentry Council. So I am honored to be here. As everyone has reiterated, more than 95% of everyone currently incarcerated today, they're coming home. And how do we want them to come home? It is so important that we have a plan. There's a process. I have to give a huge shout out to Community Partners in Action who operate and run the Reentry Welcome Center in Hartford. Deborah Galla, Beth, your leadership is amazing. Deborah Galla, who is running around getting those cell phones, and her staff who are there to greet and welcome people home is amazing. I've been there. I was there this week. What we're doing is right now we had 2 people dropped off this morning, as a matter of fact, and that doesn't happen without the support. And I have to give a huge shout out to Trina Sexton with DOC. Her staff are working hand in hand with us to have these warm handoffs to make sure that folks are coming back with a plan. We know exactly who's coming and when. DOC has transported, since we opened our doors in September of 2018, I have that we have had at least 83, as of the end of February, we've had 83 DOC drop-offs directly to the center. And so those numbers are increasing as we move forward as well. When folks arrive, right now the staff are wearing PPE, so we're all wearing masks and gloves. As soon as the person is about to enter the center, they're given a mask and gloves as well. We are welcoming them home a little differently than we were before, but it's making sure that everyone is protected, the staff and the individual coming into the center. What we do from there is we have a packet, we do an intake with them, we're giving them a charged cell phone, like Beth was saying, charged cell phone, gift cards, food gift cards, bus passes, gift cards for clothing. We're making sure that folks, that housing piece is key, and like Beth mentioned, we're working closely with Connecticut Coalition to End Homelessness, Journey Home, which is part of our coordinated access network for the Greater Hartford region. We are working with DOC. We're on conference calls all the time, trying to make sure these individuals who are identified end of sentence homeless are not released to the streets with nothing. And so we're kind of flying the airplane and changing the oil at the same time while it's in the air. And so we're working through processes and agreements, but we are making sure that folks are not when they leave the center, they don't have a place to go. The staff are case managing, the Reentry Welcome Center staff are case managing these individuals, staying contact, some daily contact with them. And so they're being sheltered right now in motels and hotels locally. There are funds, diversion funds that we're trying to get. We're talking, our next step is to talk to local landlords to see if we can get funds to divert them, not even to enter the shelter system, but to divert them out of those hotels and into sustainable housing. So that's the next piece that we're working on right now. DSS, they're not on site with us due to the social distancing piece. So we're literally doing paper applications and driving them over to DSS and handing them off, making sure that the food stamps are turned on as quickly as possible. What else? there's just a lot of communication, a lot of this coordinated effort right now. There was that before with over 40 partners that we had at the center. Now we're trying to do things like, for example, Mary Hennessy and American Job Center doing this work, her work remotely. So there's still job readiness being done remotely, Strive, and there's so many other partners that we've learned recently that are doing things virtually, AA, NA meetings, the healthcare, telemedicine. We're working closely to make sure that all these components are connected to the individual coming home. So there's just a lot of communication, just in a different way, and then the staff. The main number for the center is on our door, and it's also being transferred to the staff at the Reentry Welcome Center, so it's not going unanswered. That if somebody does make a call to the center, it is being transferred to staff members, and they are responding to those phone calls. We talked about. We do have some medically challenged individual coming next week, and so we're working on that. We'll need a wheelchair, and CPA is working on providing that. So there's just a lot. We're trying to make sure every individual has a plan and moving forward what that looks like for each individual.
Well, thank you so much, Sue. What I'd like to also say is, these things give me some thoughts on our ctreentry.org site, and is where we have Sue's been sending information about what's available in the Hartford region, what's shut down, what's being done virtually. If anybody on this call has information that they'd like to share with us about things that are available, what else we could put up there as I'm thinking about it is, what is needed. If various organizations have some needs, like Beth was talking about, cell phones or donations or the like, to impact those individuals in a positive way, then we can also put that up. But if anybody has any suggestions of what we could do to augment that site, to make it better, please do let us know. I know one thing that I saw in the New York Times article was a woman whose, I believe, the fiance was inside, and in Rikers, and they were talking about people being released, not knowing what to do to prepare themselves for COVID. If they weren't getting tested, which leads to, I'm pretty sure not everybody being released is being tested. So what are the things they could do? We worked with Transitions and DOC to create handouts that are posted in all the facilities that everybody receives. They're in English and Spanish at this point, about what to do with what are symptoms. We're adding the new symptoms as they come on, the loss of smell, the loss of taste, as well as just a primer on some of the basic services and phone numbers that people can call if they have concerns about symptoms, but also just regular basic services like DMV and public transit and the like. So one of the things that, I'd like to shift to a little bit is, and we've had this conversation, Lisa and Beth and Daryl, is, let's say there are more people released, and this has to be unprecedented. I think one of the frustrations that we had was, this is being someone who works on a public campus and seeing that schools aren't going to be coming in and back until the fall, and hopefully we turn the curve and are in a much better situation by then. So dorms and things like that would be tremendous opportunities they're already being used for frontline workers in the health field. Why not folks who are working in DOC facilities who pose the greatest risk to their families, but also to people inside and coworkers, if not people being released to homelessness or the like. And Lisa, I wonder if you have any thoughts on that.
Housing, I think that's a phenomenal idea. It's being done in other states at other universities. Yale has now just mentioned something around creating housing for first-line workers. But I think that, what that gets to is like an absolute deep and urgent need for creative approaches. We don't get with this one to just like sit back and think, well, what if we, maybe I'll mention this like in a month, it's like now, it's literally right now. So when you look on the, some like health data modeling groups have put together stuff where you can pull up each state and model what the infections are looking like. And like, our peak, our first peak, there may be additional ones, is due in about 2 weeks, 2 to 3 weeks. So we have to do this stuff now, and it has to be extremely creative. Like only being able to buy 2 cell phones at a time is absurd and just not going to be able to meet our needs right now. And so whatever rule that is, like have to be actively worked on and eliminated ASAP. We need like stocks of cell phones. We really shouldn't be letting anybody come home without a phone. It's not safe at this point in time. They need to be able to reach out and contact people if they're not feeling well and to get guidance. And this is stuff we need to be able to turn around like within a week. It's crazy stuff like that, but I'm confident that this is possible. We see it happening in all different industries, factories being changed overnight from making beer into hand sanitizer or clothes into face masks and, other machines into ventilators. Like this is stuff we have to do. It is possible. I think we have to really think outside the box. What will be required is, I can't say it enough, like absolute transparency from the DOC. I think we really firmly need that. You are simply unable to effectively plan if you don't know what you're planning for. So we need some concept of what we're planning for in order to safely meet people's needs. So I just highlight there like the real urgency and then the real need for absolute creativity. So I love that idea. Like you have dorm rooms sitting empty. That's terrible, right? That's an absolute waste of state resources if you're not then using those to house people who need housing. It doesn't make any sense.
Or possibly, I imagine, at least having people stay there for 14 days prior to being released to their families or the like, right?
Absolutely. Like we know that helps. We're doing that for healthcare workers. We're hoteling and dorming healthcare workers who are scared to bring infection back to loved ones at home or small children or ill spouses or whatever. And the same should be for our correctional staff. So they have a real, like, looking at the numbers posted on the DOC tracker today, the correctional staff are being affected at a higher rate than incarcerated people. And we have to bring them into our planning as well. How are we helping them, helping protect their families, helping them stay healthy? I think it's all of that.
Well, and I think, this is something for me in talking with you as frequently as I have, and Dr. Wang, is, you don't want to be alarmist to people, but when you see what's happened in other countries with, correctional or nursing home employees being so hit hard that they don't even show up, and then you have the issue of no one being able to care for people inside, and then the National Guard's getting called in and things like that. I think those are the stuff that we have an opportunity to avoid, we can avoid, and, the justice system is nationally or generally risk averse. I mean, and I think that the whole point that you're making about this is a public health crisis, there has to be a marrying of that, or at least the urgency has to be understood from the public health lens primarily. Absolutely. At this point.
Absolutely. And the other thing I would say is, oh my goodness, I just lost my train of thought. You said something a second ago. Oh, alarmist. Yeah, that's out the door. Like alarmist, I'm a primary care doctor. If anybody knows primary care doctors, they're not alarmist. It's always, you're going to be okay. Don't worry. Like, we'll figure this out, right? I don't feel like that at all. And I think that if we're not alarmists about this, then we've missed the point. We are not then reading the writing on the wall from all these other countries. And the U.S. quickly rose above all other countries in the number of infections. Our only risk right now is not taking this seriously enough. There is no such thing right now as over-planning, over-releasing, over-supplying and stocking giving people what they need when they get home. That is not the fault. That's not something we need to be worrying about right now, in my opinion.
Thank you so much. And, just for the last word, I would like to mention to folks that we are going to be doing this every Wednesday, same time. We'll send out information on the next one. Our initial intention is to talk about the more of the reentry centers and the work of the roundtables and things that are going on and ways people can help. But, we're being responsive to the moment and the times, and that might change. We would also love to hear ideas from people about what you'd like to hear about. Again, we're focused on reentry. Our hashtag for this is dignity for all, and that's what we want to keep centered, is the dignity of individuals being maintained here, and understanding that in a public health crisis. And thank you so much, Lisa. I do also want to mention the site again, ctreentry.org. We have information on Transitions Clinic there. We have information on DOC and COVID and all the state agencies. We recently had a call with folks from an organization called Amelio. There's a link on our COVID page on communication, and there's access to phones there, but there's also, we'll make it more prominent, send free letters and photos to your incarcerated loved ones. And these folks are actually out of Yale and created this app, and by all appearances, you're able to send unlimited letters to your loved ones, or even people you may not know. And I know, Daryl, you had some thoughts on maybe ways that people could have a way to connect with people inside who may be feeling scared, concerned, or the like, and that being an important component to this as well. So I will then, we're at 11:17. I will thank everybody so much. Again, we aren't going to be able to get to all your questions and answers, but we will follow up with those. We'll post those. We'll send those to attendees. I want to thank Dr. Puglisi, Mike Lawler, Beth, and Sue, and Daryl. I hope you found this informative, and know that people are concerned day in and day out about this population, and that we're doing what we can, and we're trying to do it together with the people that are attending as well. So let's keep up the momentum here, and I would love the fact that we're ending with Lisa, because just keep in mind that this is a public health crisis we're dealing with. So thank you so much. We've had some calls to action, and just thanks again, and appreciate your being a part of this. And stay safe, everyone.